Well, good afternoon to all you again, ladies and gentlemen, and welcome to our second presentation of the spring session for 2024. Now, I hope you will remember that in our first session, we posed the question, what is tetralogy of Fallot? So today, we're going to look at the very close lesion in many respects to tetralogy, namely double outlet right ventricle. Many of you will be aware that there is significant controversy regarding double outlet right ventricle, and not least its relationship to tetralogy of Fallot. So this is what we're going to be discussing with you today. We're going to address the first problem. Does double outlet right ventricle have a specific phenotype? And of course, we're going to come back to the relationship between double outlet and tetralogy. Again, I emphasize that I hope many of you were with us in our last session when we specifically concentrated on what was going on in tetralogy. But we will be discussing that again. I'm sure there are many of you who would still expect to find bilateral conuses to diagnose double outlet right ventricle. But we're going to address that issue also, because in our opinion, you should no longer be looking exclusively for bilateral conuses when you diagnose double outlet. But most importantly, we're going to be looking again at the channel between the ventricles. We're going to discuss the definition of that entity. And today we're going to look specifically how we can use that entity to provide us with a pragmatic definition for double outlet right ventricle itself. But let's start by getting rid of one of the problems. Does double outlet right ventricle have a specific phenotype? Here, the answer unequivocally is no, because we're going to show you today that there are several phenotypes that are joined together because the outflow tracts are supported predominantly by the morphologically right ventricle. So there are several phenotypes that make up this group because it is specifically a ventriculo-arterial connection. Now that is important in itself, because if it is no more than a ventriculo-arterial connection, you're going to find it in patients with various types of atrial arrangement. Usually, there will be usual atrial arrangement. And today, we're only going to show you examples of hearts with double outlet right ventricle having usual atrial arrangement. But many of you will know that when you have right isomerism, it's very frequent to find patients having the ventriculo-arterial connection of double outlet right ventricle. And of course, the atrioventricular connection can change as well. So when there is right isomerism, the atrioventricular connections will be mixed. We can find double outlet right ventricle with discordant atrioventricular connections. And then the relationship is going to be very similar to congenitally corrected transposition. But today, again, I emphasize we're only going to be showing you examples of double outlet right ventricle in the setting of usual atrial arrangement with concordant atrioventricular connections. There is, however, an important point to make on the basis double outlet right ventricle is a specific ventriculo-arterial connection, because that means it cannot exist with another ventriculo-arterial connection. So I hope that no longer do we have any of you who try to describe double outlet right ventricle with transposition. Transposition is itself a different ventriculo-arterial connection. You all know it is a discordant one. And we're going to be posing the question, what is transposition, in our next session. But let's continue today with looking at double outlet right ventricle. And where is the elephant in the room? Well, for years, people argued that you had to have bilateral conuses in order to define double outlet right ventricle. But we now know, and as we're going to show you, many patients unequivocally can have a ventricular arterial connection of double outlet when there is fibrous continuity between the leaflets of an arterial valve and an atrioventricular valve. Equally importantly, we can find bilateral conuses in the setting of concordant or discordant ventricular arterial connections. And Diane is going to show you an example of that very shortly. But I'd like to emphasize to you that one of the reasons for using this criterion, bilateral conuses, was to distinguish between double outlet and tetralogy. What we're going to show you is that they can coexist. And indeed, very rarely, as you see here, we can find patients with phenotypic features of tetralogy. Here you see the phenotypic features of tetralogy. There is the outlet septum. It is deviated in anterocephalad fashion. There are the septoparietal trabeculations. And there is the squeeze at the mouth of the subpulmonary infundibulum that tells us that we're dealing with tetralogy fallow. But look at what's going on in the aortic root. There you see very nicely the extensive ventricular infundibular fold that is separating the overriding component of the aortic root from the tricuspid valve. But trace that ventricular infundibular fold, and as you see, it produces a completely muscular subaortic infundibulum. Bilateral conuses can rarely be found in hearts having the phenotypic morphology of tetralogy fallow. So we no longer need bilateral conuses so as to make the diagnosis of double outlet right ventricle. And there's a very good reason for that, because I hope you remember that one of the important principles we use when we are describing congenitally malformed hearts is the morphological method. It was introduced by my good friend Richard van Praag, and Richard emphasized we should not use one feature, which is itself variable, to describe another variable feature. Instead, we should describe the various features in their own intrinsic morphology. And that tells us that infundibular morphology is but one of the variables that we can find when both arterial trunks arise from the right ventricle. It's an important variable. We describe it when it's present, but we do not use it any longer as a defining criterion for double outlet right ventricle. And this is the more important, since very rarely we can find bilateral infundibulums in the otherwise normal heart. As I said, Diane is going to show you an example of this. It's a heart that has an apical muscular ventricular septal defect, but otherwise the heart has concordant atrioventricular and concordant ventricular arterial connections. So now let's look bilateral conuses or bilateral infundibulums in the setting of the otherwise normal heart.
This specimen was a cardiac explant and received in pathology. We removed the free wall of the right ventricle to look at the right ventricular structures. Prior to receiving it in pathology, though, in the OR, they removed the majority of the subpulmonary muscular infundibulum, the pulmonary valve, and the pulmonary trunk. So this specimen did have a complete subpulmonary muscular infundibulum, and you can also appreciate that the arterial trunks were spiraling normally from the ventricular mass so that the aorta still was forming the centerpiece of the heart. So remember that there was a subpulmonary muscular infundibulum. In pathology, the heart was cut in a long axis plane, and here you can see at the apex that there was a muscular ventricular septal defect that was previously closed by a device. What I would like to point out here is the anatomy relative to the aortic root in this heart that had concordant atrioventricular and ventriculoarterial connections. You'll note that In this area is the anterior or the aortic leaflet of the mitral valve, and here is a bar of muscle that is separating the aortic valve from the mitral valve. If I put my gloves on the mitral valve, and this is the reason that I wore blue gloves for this specimen, because you can see through the mitral valve, but not through that muscle bar that separates the atrioventricular from the arterial valve. So that in this area, the aorta is supported by a complete muscular infundibulum. If we look at the opposite aspect, again, you can see that muscle bar separating the aortic leaflet of the mitral valve from the aortic valve itself. And again, you can see my blue glove through the mitral valve, but the muscle above it is separating the two valves from one another, so that you can have concordant or even discordant ventricular-arterial connections where both arterial trunks are supported by a complete muscular infundibulum.
So let's get back now to double outlet right ventricle in relationship to tetralogy. So we told you double outlet is defined on the basis of its ventricular-arterial connection. We showed you last time, however, that tetralogy is defined on the basis of the phenotypic morphology. And we also showed you last time that the two can coexist. So let's look at that again. And let me show you this beautiful computed tomogram that was produced by Neeraj Pandey. I introduced you to Neeraj during the last session. He is a consultant radiologist, the All Institute of Medical Sciences in New Delhi in India. And he produces now these exquisite virtual dissections for me. And here he's showing you this example of tetralogy. There you see the phenotypic feature, malaligned outlet septum, the abnormal septoparietal trabeculations. There is the squeeze that tells us we're dealing with tetralogy. And when we look at the relationship of the aortic root in this particular heart, as you see in a cut through the computed tomographic data set, there is the morphologically right ventricle, there is the aortic root, and there is no question that in this patient, the aortic root, along with the pulmonary trunk, in the setting of tetralogy of Fallot, are supported by the morphologically right ventricle. So here you're seeing it in a computed tomographic data set. Let's now ask Diane to show us an example of double outlet right ventricle in the setting of tetralogy of Fallot.
This specimen has a ventriculo-arterial connection that is one of a double outlet right ventricle. And if I tilt the specimen on its apex and reoppose the edges of the aorta, we can see that this aorta is much more committed to the right ventricle than it is to the left ventricle. It also exhibits the phenotypic features of tetralogy of Fallot, so that we can see the outlet septum here is deviated in anterior superior fashion, and the defect extends between the limbs of the septomarginal trabeculation and is an outlet defect, just as we see in tetralogy of Fallot. The body of the septomarginal trabeculation is here, with the cephalic limb rising up to join the outlet septum, and the caudal limb is here, giving rise to the medial papillary muscle, and in this case extends to reach the inner heart curvature or the ventriculo-infundibular fold, and that ventriculo-infundibular fold is the muscle bundle that separates an atrioventricular from an arterial valve. In this case, the conduction tissue would also be protected along the posterior inferior border by this muscular bar. It's also very important to remember, in addition to the anterior cephalic deviation of the outlet septum, we have the hypertrophy of the septoparietal trabeculations, which also put an extra squeeze on the right ventricular outflow tract. In some specimens with the tetralogy phenotype of double outlet right ventricle, you can have a subaortic muscular infundibulum, but in this particular specimen, there is fibrous continuity within the left ventricular outflow tract between the mitral valve and the aortic valve.
So if double outlet can coexist with tetralogy, then how do we define double outlet in itself? Do we use a 50% rule? That can be difficult because it can be very problematic to decide when more than half of the aortic root is supported by the right ventricle. So instead, should we use a 90% rule? But then what happens when we have 75% override? Neither of those is perfect. So can we find a more practical means of making the distinction between concordant, discordant connections and double outlet ventricle? And I believe it all depends on what happens to that channel between the ventricles. So let's look again at this channel between the ventricles. And now I'm reverting to another of these exquisite computed tomographic data sets that was prepared for me by Neeraj. We showed you this one in last session on tetralogy of Fallot. So here we're looking at the typical arrangement in tetralogy of Fallot, where the aortic root is more or less balanced between the ventricles. So here we have that 50% arrangement, and should we decide whether it's concordantly connected or whether it's double outlet? And it all depends on what's happening in this triangle of space that we emphasized in our last session, which is subtended beneath the aortic root. And what we showed you is that relative to that triangle of space, there's a communication from the left ventricle into the aortic root. There's a communication from the right ventricle into the aortic root. Now, what can we say about those communications? The left ventricle entrance to the aortic root is the outflow tract for the left ventricle. So it follows, if that is narrowed, it will produce subaortic obstruction. So we need to know whether that is wide enough for all the flow coming into the left ventricle, the setting of an overriding aortic root, is able to reach the aorta. But from the stance of correction, from the position, the extent of override, we need to know about that right ventricular entrance to the aortic root. Because always, during surgical correction, it is that right ventricular entrance, the aortic root, that will be closed by the surgeon so as to restore septal integrity. And we're going now to look at that right ventricular entrance to the aortic root when we have more or less 50% override, but when we have almost exclusive origin of the aortic root from the right ventricle in the setting of tetralogy. So now let's ask Diane to show us those two arrangements.
This heart with tetralogy of Fallot has been cut in a 4-chamber plane so that we can see that the aortic root is relatively balanced above the crest of the ventricular septum. So approximately 50% committed to the right ventricle and 50% committed to the left ventricle. Here, from the crest of the muscular ventricular septum, you can see the left ventricular entrance to the aortic root, which is actually forming the left ventricular outflow tract. Here is the right ventricular entrance to the aortic root, which is the area where the surgeon will place their patch in order to put the aorta back into direct communication with the left ventricle and the left ventricular outflow tract. This specimen is cut in much the same way as the last specimen we looked at with the balanced aortic root in the situation of tetralogy of Fallot, whereas here we see the aorta is much more committed to the right ventricle than it is to the left, and this is indeed a double outlet right ventricle. So here you can see the space that is the left ventricular entrance to the aortic root, and a much larger space that is the right ventricular entrance to the aortic root. So this area where my probe is where the surgeon will place their patch to put the aortic root back into the left ventricle and restore that left ventricular outflow tract.
So what you have seen is tetralogy fallow, 50% override, tetralogy fallow arising almost exclusively from the right ventricle. Now, in conventional nomenclature, when the surgeon closes the ventricular septal defect in the setting of regular tetralogy fallow, the surgeon is talking about the right ventricular entrance to the aortic root. But currently, when a surgeon is correcting regular double outlet right ventricle, the space that is called the ventricular septal defect is not the part that the surgeon closes. We can look at that in another computed data set prepared to me by Neeraj. You can't see the pulmonary root in this particular patient, but it was unobstructed. I'm going to show you that subsequently. But let's look at the aortic root. There it is. And here we have a subaortic infundibulum. So this is classical tetralogy. This is classical double outlet right ventricle with subaortic defect. And there is the defect. And most of you, I'm sure, still will be calling that space the ventricular septal defect. Now we know that in tetralogy fallow, regular tetralogy fallow, the surgeon closes the ventricular septal defect. But it would be a disaster in this situation to close the hole that is still typically called the ventricular septal defect. And what, in fact, the surgeon does when we have double outlet right ventricle, as we're going to emphasize for you, the surgeon places a patch within the cavity of the right ventricle so as to tunnel the aortic root through ventricular septal defect, as it is called, so as to restore septal integrity. And it is this fact that to our minds gives us the pragmatic definition for overriding arterial roots. If you ask the surgeon when sending the patient to the operating room to close the ventricular septal defect, you must have already made the decision that the ventricular arterial connections were either concordant or discordant. On the other hand, if you ask the surgeon to tunnel the defect, the arterial root, then you will have made the decision that the ventricular arterial connection is one of double outlet right ventricle. And that, we believe, provides us with the pragmatic definition for double outlet right ventricle. So now we have our pragmatic definition. We know that double outlet right ventricle is not a phenotype in its own right. So what is it that distinguishes the various types that we group together in which we ask the surgeon to tunnel the defect to an arterial root? And it is, of course, the location of that channel between the ventricles. And remember, that channel is going to be the outflow tract for the morphologically left ventricle. And when we look at this variation, we can go all the way back to 1972 and the stellar paper that was written by Maurice Lev and his colleagues classifying double outlet right ventricle. Because as Lev pointed out, in most instances, the defect is subaortic. The second commonest variant is found when the defect is subpulmonary. But in some instances, the defect doubly committed. Sometimes it is non-committed. And indeed, exceedingly rarely, we can find hearts with double outlet right ventricle when the ventricular septum is intact. So how do we determine and describe these different entities? And all depends on the building blocks of the outflow tracts. What are those building blocks? We have the outlet septum, we have the ventricular infundibular fold, we have the septoparietal trabeculations, and we have the septomarginal trabeculation. And it is an understanding of those entities that is the key now to describing double outlet right ventricle. So I'm going to ask Diane now to show you the definitions we use to define these different entities, and she's going to show you that in the setting of tetralogy of Fallow.
We're going to look again at the heart that had the tetralogy variant of double outlet right ventricle and the building blocks relative to some of the areas that may be in peril relative to the conduction tissue during surgical repair. Here is our outlet defect, which extends between the limbs of the septomarginal trabeculation. The outlet septum would be safe for surgical repair, as would be the hypertrophied septoparietal trabeculations. The septomarginal trabeculation is also safe. The anterior limb houses the first septal perforator in many cases, and resection of this area may damage the first septal perforator. The caudal limb of the septomarginal trabeculation in this case extends to reach the ventriculo-infundibular fold, so that there is a muscle bar along the posterior inferior aspect that would be protective of the conduction tissues. If this muscle bar is extremely thin, this could be a danger zone, as well as if there is no muscle bar and we have fibrous continuity between the tricuspid and mitral valves along this posterior inferior border. So that this is a major danger zone when you have a perimembranous ventricular septal defect or a fibrous posterior inferior border.
So let me emphasize the points that Diane has just made for you and show you how these exist now in a diagram. There is the defect. We're illustrating the situation with the defect in subaortic position. And what you see there is the outlet septum. As Diane has emphasized, it separates subpulmonary, subaortic outflow tracts, and it is safe providing that the surgeon takes care of the attachments, the leaflets of the arterial valves on either side. Here is the septomarginal trabeculation. Its body is safe, but usually the defect opens between its limbs. And its anterior rim is relatively safe, but beneath it is the first septal perforating artery. It is the caudal or the inferocaudal limb of the septomarginal trabeculation that leads us to the danger area, because there lurking behind the posterior inferior rim of the septomarginal trabeculation is conduction axis, as Diane has shown you. And it is at greatest risk when there is fibrous continuity between the leaflets of the mitral and tricuspid valves. What Diane has shown you, however, is that it can be protected when there is fusion between the caudal limb of the septomarginal trabeculation and the ventriculo-infundibular fold. And the ventriculo-infundibular fold, of course, is no more than the inner heart curvature. It is possible to resect the ventriculo-infundibular fold, remembering that resection takes you outside the heart. It puts at risk, on occasion, the branches of the coronary arteries, but providing it's sewn up again, there will be no problem. So, surgical danger areas depend on recognition of these features, and it is recognition of these features that then distinguishes the different phenotypes to be found in the setting of double outlet ventricle. Remember that very rarely the channel between the ventricles can close, and that gives us intact septum. And here is a very nice example of double outlet right ventricle with an intact ventricular septum. There's no question in this instance that there is double outlet right ventricle. There is the aorta, pulmonary trunk. There had been an interventricular communication, but it has closed spontaneously. So now, very nicely, we can see some of these building blocks. There is the outlet septum separating the subaortic subpulmonary outflow tracts, and each aortic root is supported by its own infundibulum. Another classical example, double outlet right ventricle. but in this instance with an intact ventricular septum. But it is rare to find hearts with an intact ventricular septum. Almost always there will be the channel providing the outlet for the left ventricle. And it is the location of that channel that determines the clinical situation and determines phenotype. Usually, when the channel is in subaortic position, the arterial trunks are so-called normally related, and that gives us a clue that the defect is going to be subaortic, as we'll see in the demonstration by Diane.
This is a specimen that has a double out right ventricle and arterial trunks that are spiraling in normal fashion from the ventricular posterior and to the pulmonary trunk. Looking into the pulmonary trunk, it is supported by a complete muscular infundibulum, and this heart was put back together so that we could cut it in 4-chamber plane to have a look at how the defect was repaired. So if I flip this portion over and we look at this heart now from the spine towards the sternum, we see the tip of our right atrium here. This is our hypertrophied right ventricle, the aorta, and our small left ventricle, and a portion of the mitral valve. You can see that the defect is the entrance to the aortic root or the left ventricular outflow tract, and also that the defect was in subaortic position, with the aorta mostly committed to the right ventricle across the interventricular septum. This also shows us nicely how the surgeon placed the patch across the right ventricular border of the defect to effectively put the aorta back into direct communication with the left ventricular outflow tract. The borders where the surgeon places the patch are at the ventriculoinfundibular fold, so you can see a little bit of muscle there. Along the posterior inferior border of the defect, where the tricuspid valve and the mitral valve were in fibrous continuity in this specimen, and along the outlet component of the subpulmonary muscular infundibulum. So the patch is angled from the ventricular septum towards the inner heart curvature to place the aorta back into communication with the left ventricle.
And we can now show the situation of a subaortic defect again using computed tomography. So this is the reconstruction of the case that I've shown you previously, where the aortic root is arising exclusively from the right ventricle along with the pulmonary trunk. There is the aortic root, and there is the outflow tract, the left ventricle, which still, in many instances, is called the ventricular septal defect. And as we have emphasized, that is the outflow tract for the left ventricle. And the role of the surgeon during surgical correction is to place a patch in the right ventricle so as to close the aorto-right ventricular communication. Now we can rotate this data set so that you can look up into the aortic root and you can see the margins of that aorto-right ventricular communication. Note that in this particular patient, there's also a solitary coronary artery. This is the beauty of computed tomography. It shows you all these features. And you note that in this particular patient, as we've shown you already, there is a completely muscular subaortic infundibulum. If we look posterior-inferiorly, there's fibrous continuity between the leaflets of the mitral and tricuspid valves. The defect is membranous. What we need to know, that is the area where the conduction tissue will be at greatest risk. What we need to know is the margins around which the surgeon will place the patch so as to tunnel the aortic root back into the left ventricle. And the fact that the surgeon has to tunnel the root tells us that we are dealing with double outlet. So when we have a subaortic defect, if the subpulmonary outflow tract is unobstructed, then we are dealing with the VSD phenotype. If associated with subpulmonary obstruction, we have the combination of tetralogy with double outlet ventricular arterial connection. But we can also find the situation, oftentimes with normally related arteries or side-by-side arteries, in which the defect is juxta-arterial. And oftentimes the features of those hearts is that the outlet septum is fibrous rather than muscular. So Diane is now going to show you a lovely example of double outlet right ventricle with a doubly committed defect, which is also juxta-arterial. And she's going to show you how very frequently that lesion can move towards double outlet left ventricle. And indeed, in many instances, it's now described as double outlet both ventricles.
We're looking at this heart from the anterior aspect and in attitudinally appropriate fashion, so that the free wall of the right ventricle has been previously removed, and in a moment I'll show you that the heart has been sectioned in parallel with the interventricular septum. Looking at the arterial trunks as they leave the ventricular mass, the aorta is anterior and rightward of its usual position, so that it is now side by side and to the right of the pulmonary trunk. The pulmonary trunk is also of a much smaller caliber than is the aorta. If we look at the sectioned components of the specimen, you can see that this is the interventricular septum, and remember, the right ventricle will be anterior to that. Here we see the anterior-most portion of the morphologically right atrial appendage and a little bit of the tricuspid valve. So we're looking at this specimen from the spine towards the sternum. There is an interventricular communication. You can see the crest of the muscular interventricular septum. Looking at the arterial valves, they are in fibrous continuity with one another, and this is a doubly committed and juxta-arterial defect. If I push the pulmonary trunk backwards a bit, you can now see that small fibrous outlet septum just at the tip of my probe. When the outlet septum is fibrous and not attached to the cephalic or the caudal limb of the septomarginal trabeculation, the arterial roots can be arranged so that they arise from either ventricle and can be described as a double outlet both ventricles. So if you remember that triangle of space that we've been talking about, the arterial trunks are free to float above or within that triangle of space and above the interventricular septum.
So then we have to look at the other variants. And the second commonest variant, rather than the one you've seen just a moment ago, the juxta-arterial defect, is the subpulmonary defect. And this, of course, is the Tausig-Bing heart. It's part of a spectrum that leads to transposition or discordant ventricular arterial connections. And here, the arterial trunks are usually side by side, or else the aortic root is anterior and marginally to the right. As you're going to see, they can be found with bilateral infundibulums or with pulmonary to mitral fibrous continuity. So first, let's again ask Diane to show us an autopsy example of the Tausig-Bing variant of double outlet right ventricle.
This is another fetal heart where I folded the free wall of the right ventricle away, and we can see the tricuspid valve in the inlet. You'll also appreciate that the ventriculo-arterial connection is one of a double outlet from the right ventricle, and this heart is showing us the so-called Tausig-Bing variant of double outlet right ventricle. The aorta and the arch are hypoplastic, secondary to the malalignment of the outlet septum, and as well this little muscle bar that's crossing from the outlet septum to the infundibulum. The aorta is supported by a complete muscular infundibulum in this case. The pulmonary trunk is mostly committed to the right ventricle, and you'll note that within the left border of the defect, the pulmonary valve and the mitral valve are in fibrous continuity with one another. This defect is an outlet defect, as it does extend between the limbs of the septomarginal trabeculation. And you'll note that the caudal limb, this time, is in continuity with the outlet septum rather than the cephalic limb, as we saw in the tetralogy variant, being in communication with the outlet septum. This muscular bar will protect the conduction tissue when this specimen is repaired, and the surgeon will place the patch along these borders to place the pulmonary trunk back into communication with the left ventricle. But in that case, we end up with discordant ventriculo-arterial connections, so that the surgeon will then have to do an arterial switch and place the pulmonary valve, or the pulmonary artery, I should say, back into communication with the right ventricle, and the aorta back into communication with the left ventricle, of course, moving the coronary arteries as they normally do in an arterial switch. This outlet muscle could be resected to open up the new pulmonary outflow tract once the arterial switch is performed. I have another specimen that shows us a variation of the so-called Taussig-Bing variant of double outlet right ventricle. And if we look sort of up the apex of this very hypertrophied right ventricle, you can see the stenotic subaortic outflow tract that is supported by a complete muscular infundibulum. And here is our malaligned outlet septum. The pulmonary valve is overriding the septum, but mostly committed to the right ventricle, with this subpulmonary defect extending between the limbs of the septomarginal trabeculation. Again, here you can see the caudal limb of the septomarginal trabeculation extending up to join that malaligned outlet septum. The difference between the last specimen and this specimen is that the pulmonary valve is supported by a complete muscular infundibulum, so that you can see the mitral valve here is separated by that muscle from the pulmonary valve. So you can have bilateral subarterial muscular infundibulums in double outlet right ventricle, but as we saw in the last specimen, it is not a requirement.
But I can now show you an example, again as demonstrated by Neeraj from the All India Institute in New Delhi. So here is a short axis cut through the heart, and here you see the aortic root, which in this instance is anterior and marginally to the right of the pulmonary trunk. But both of the arterial roots are arising from the morphologically right ventricle, as Neeraj shows you in this virtual dissection. So there, the anterior aortic root in front of the pulmonary root, and you note that in this instance there are bilateral infundibulums. There is the inner heart curvature, or the ventricular infundibular fold, separating the pulmonary valve from mitral valve. So the key features are the pulmonary left ventricular communication. Again, this is the outflow tract for the left ventricle, but the major feature for the surgeon is the pulmonary right ventricular communication, because this is the space that will be closed so as to put the pulmonary root back into the left ventricle. So when we look at the heart from the front in another of Neeraj's beautiful virtual dissections, there we see the margins of the space around which the surgeon is going to place his patch so as to tunnel pulmonary root into the left ventricle. We're looking through the anterior aortic root, so cranially we find the outlet septum. In this particular heart, there is an infundibular fold separating the pulmonary, aortic valve rather, from the tricuspid valve, and also, as is usually the case in double outlet right ventricle with a committed defect, the defect is opening between the limbs of the septomarginal trabeculation, but in this instance in subpulmonary position. And because the caudal limb, septomarginal trabeculation, is fused with the ventricular infundibular fold, in this particular patient, the defect itself has exclusively muscular borders, so it is a muscular outlet defect. And here we can see it in a cut through that data set, and that is where the surgeon is going to place his patch so as to tunnel the pulmonary route through the left ventricular communication into the left ventricle. But that, of course, is going to produce transposition physiology. So in the Tausig Bing variant, the surgeon will also have to perform the arterial switch procedure. Now, it's also possible to find the defect in non-committed position. And then the feature of the non-committed defect is that it no longer opens between the limbs of the septomarginal trabeculation, also known as the septal band. And although anatomically it's non-committed, some of these defects can still be tunneled to an arterial route, whereas others unequivocally are non-committed. And here we see a particularly interesting defect. For quite some time, I thought this particular heart had a subaortic defect. So let's look at what's going on. There is the aortic root, supported by an extensive subaortic infundibulum or conus. There is the pulmonary root, with its own extensive subpulmonary infundibulum, both supported by the right ventricle. Separating them, we have the muscular outlet septum. But when we trace the muscular outlet septum in this particular heart, we see that it inserts between the limbs of the septomarginal trabeculation. And it is that feature now that tells me the defect, which you are seeing here, channel between the ventricles, it is opening, in fact, between the ventricular inlets. Despite that, it has a muscular posterior inferior border. It is a perimembranous defect. It can be channeled into the aortic root, but now, having reconsidered this heart, I would say that the defect is non-committed rather than being subaortic, although a channel could be constructed within the right ventricle so as to put that defect into continuity with the aortic root. So it's moot on some instances as to whether the defect is considered to be subaortic or non-committed. In this heart, however, there is no question but that the defect is non-committed. It's the aortic root, pulmonary root, and there is the defect. It is a muscular defect within the inlet part of the ventricular septum. And as you see, the tricuspid valve is interposed between that muscular inlet defect and both of the arterial roots. So we can put everything together, and I think we can clarify the situation by showing you the double outlet right ventricle is not a phenotypic entity in its own right. Rather, it is a group of lesions unified because they share the same ventriculo-arterial connection. The key points: that channel between the ventricles is the outlet for the morphologically left ventricle. It is a communication between the left ventricle and usually one or other of the arterial roots. And the take-home message is that the surgeon, so as to repair double outlet right ventricle, creates a shelf within the right ventricle so as to tunnel the arterial root, be it aortic, be it pulmonary, back into left ventricle through the left ventricular communication with that arterial root. Again, that gives us a pragmatic means of defining double outlet right ventricle. If you have asked the surgeon to tunnel one or other of the aortic roots into the left ventricle, then of necessity you will have made the decision that your patient has double outlet right ventricle. Well, welcome to you all for the discussion session to today's presentation. Diane is now with us, I'm pleased to see, and Adrian, I think you are also with us, are you not?
Yes, I am. Thank you.
Right, so Norman, you have to catch your aeroplane rapidly, so we should let you kick off.
I think this is very interesting from the point of view of an echocardiographer, especially doing two-dimensional echocardiography. I still want to hold you to whether, I mean, some of them are very obvious, whether there is doubly committed, a double outlet or a not doubly committed defect. And the other issue about echocardiography, and I think also for MRI and CT scanning, is that there's an interesting set of circumstances going on in the heart because the ventricles are twisting in one direction and the great vessels are fairly stable. So that when you look at the heart when it's beating, the defect has a variable commitment to the left or the right ventricle. To the arterial roots. And so it becomes very difficult. And I'd like to ask you whether you would hold to considering double outlet as a certain percentage. Certainly, I would think the time to do it on an echocardiogram would be at end diastole, where the heart is relatively relaxed in terms of its spiraling. So can you answer that question, Bob? Are we going to take it as a 50% rule or a 75% rule, or are we just going to discard all of that information? Because I think that's important for the viewers over here to understand, because many of them are going to use these old terms, and you see them all the time when you talk to people, that they talk about bilateral conuses and not bilateral conuses. So can you give me an idea of about what the override of the arterial valve of the ventricular septum might be before we can make some kind of a communication there?
Well, what I'm trying to do, Norman, is to move away from that, because I recognize the problem that you have. I mean, we as morphologists do not have the same problem. So we do not see the arterial roots moving one way or the other. What we've tried to demonstrate to you today is that irrespective of that degree of override, when the arterial root is overriding, there will be a left ventricular entrance to the root, there will be a right ventricular entrance to the root. So does it really matter how during the cardiac cycle that root varies? Because irrespective of whether it's 25%, 50%, 75%, 90%, always to put that overriding root back into the left ventricle, the surgeon will need to close the right ventricular entrance to the root. So the key point is the left ventricular entrance stenotic? If so, the surgeon will need to enlarge it. But again, irrespective of that point, having established that there is a sufficiently capacious entrance from the left ventricle into the overriding aortic root, the patch will need to be placed within the right ventricle. So the surgeon is going to need to know the margins, not of the defect, the left ventricular entrance. The surgeon is going to need to know the margins of the right ventricular entrance to the overriding arterial root. So again, I put the question back to you. Does it matter whether the override at different times in the cycle seems to be 40%, 50%, 60%, 70%? Still, are you not? You're going to have to tell the surgeon the margins of that right ventricular entrance to the overriding arterial root.
Yeah. Well, yes, I think that just looking at many echocardiograms of double outlet right ventricle, it's fairly obvious most of the time that the ventricle is the arterial valve is committed to the right ventricle. That is certainly the case. But there are times where it becomes difficult, and I think that there's a tendency amongst echocardiographers and surgeons to talk about double outlet as different from tetralogy, because I'm just talking about with the normally related vessels. The reimbursement is much higher for double outlet than it is for tetralogy FLO.
Well, in
So
that case, we should call them all double outlet. Then the
that's
surgeon
correct.
gets some money. But I mean, yeah, you will accept that that is not a problem that involves us as we are trying to work out and trying to explain what is going on in terms of the morphology. And again, it is, I come back again, and I accept that this may be difficult for you. You may not, as an echocardiographer, be able to see at the same time all the margins of that right ventricular entrance to the overriding route. But by scanning, surely it is feasible for you to do that.
Well, 3D
I have here the one
solves some of that.
Can I make one comment on the Norman's really discussion about this?
Of course.
Yes. So it's very interesting, the really observation. I entirely agree with Dr. Silverman that the degree of overriding changes throughout cardiac cycle. Yes. And then the happening was that we do 3D printing for cardiac surgeons in many, many DORV cases. And then initially they printed the hearts in endosystole, because that is the most accurate, the best image quality we can provide in heart rate of 100, 120. So then we find that what surgeon we're going to see in surgical scene is completely different from endosystolic imaging. So even if the image quality is not great, thank you, is not great, we begin to do the 3D printing for end-diastolic images. Believe that they were doing the right thing. Happening was, yes, surgeons are going to do the surgery simulated in end-diastole, but the outcome of surgery will be in endosystole. So there is a significant discrepancy in description and observation from image standpoint of view and what is in surgical scene, and immediately after surgery to do the epicardial echocardiographic finding, what the outflow track, there is a significant discrepancy. So that should be really understood. So the heart is not static, and then even if the surgery is done in the static situation, you always need to think about the consequence of that surgery when heart is beating out. So therefore, it's a very complicated one. I think Dr. Silverman's description about this is not just for the overriding issue, but more importantly, the changing issue of this geometry throughout cardiac cycle, preoperatively and postoperatively.
But June, you continue to miss the point, irrespective of what you say.
Oh yeah, I 100% agree with you. That's not the point I was discussing.
No,
100% agree with you.
Irrespective of that, the area that the surgeon needs to know about is the right ventricular entrance to the overriding route. And
no argument about that. I was not talking about that.
Indeed. So in many ways, what you are saying, what Norman is saying, is that all this old argument we had is immaterial to the point that we are discussing anatomists.
Agree. Yeah.
Adrian, let's ask the surgeon.
Hello. Very interesting discussion. And I kind of do the Jewish rabbi thing, and I agree with all of you, because yes, for me, it's a matter of anatomy, but it's also a matter of flows. If we look in systole, we should look at each great vessel And if we can decide on where is the flow coming into that great vessel in the majority, is it coming in totality from one ventricle and the greatest majority from the other ventricle, or from the same ventricle will provide the greatest majority of flows? So that's something that is a functional definition related to the systole, as Shi Jun said, because yes, we operate in a cardioplegic heart. The heart is in diastole. And what we see, it will be something like this. If I can share my screen, it will be this. This is a 3D printed heart. And I have to take you a bit to tell you that this is a left-hand topology of a morphologic right ventricle located on the left side of the heart. And if you see, I put my probes here. This is into the aorta. Aorta is anterior. And the one is in the back. If you see here, it pushes here where the pulmonary trunk is. And if you look from underneath, you'll see where the VSD, the entrance from this ventricle, which is a morphologic left on the right side, is into the great arteries. So the 3D print models will give us a diastolic aspect of a double outlet right ventricle, however we want to call it. But then when we assess it in systole, where we need the flows. We need to understand how much of the flow will go in each great vessel. So that links to the streaming concept that we haven't touched on. It links with malpose great arteries, because a lot of people will start from describing malpose great arteries and then go to understand what a double outlet is. And then we have to remember that we look at the entrance into the interventricular channel always from the morphologic right ventricle. And this is another example how this will be difficult for a surgeon for us when the morphologic right ventricle is on the left side. And in the end, I'd like to emphasize that this is a spectrum within a spectrum. So when people look at the Tausig being, they should not start from the concordant VA connections, because they don't understand it. They have to start from the discordant VA connections.
Oh, yes, of course.
From the transposition side in order to understand Tausig being. Otherwise, you don't understand it if you start from the concordant VA connections. So
that is the immigrant from PGA.
With respect, Adrian, you still have to know where you're going to put your patch. So that's the point we're making today, irrespective of everything you're telling us about.
100% agree. Can I show the couple of slides that I prepared for you, the while you're presenting? So let me share this screen. So can you see my slide? So this is a famous drawing in the textbook and journal articles and everything. So I'm fine with defining the right ventricle margin and left ventricle margin. Currently, new innovation is that if it is aorta right ventricle tunnel or communication, or aorta left ventricle tunnel or communication. I do not have any issue about that. But however, I had a problem in calling this aorta right ventricle communication with VSD, which I realized today, Professor Anderson stopped calling this as VSD, which is absolutely important to the recognition of the fact that we should not call this VSD. I agree that the VSD is not definable. I'm not talking about that, okay? So having said that, so that is the one thing that importantly is that aorta left ventricle, pulmonary left ventricle, right ventricle works for the cases with subaortic and subpulmonary defect, as the Professor Anderson explained. But however, the problem arises when the VSD is remote. Why? So that is important that your reader for the recent article need to understand that is not the concept applicable to whole DORV. That concept is applicable when one semilunar valve is overriding. But however, in those situations, most of the morphologists, most of the cardiologists, most of the surgeons understand. But the problem is that when you have this defect, and then it is very difficult to define aorto left ventricular, aorto right ventricular communicating channel. That should be understood. And then going back to there, so, okay, let me go down a little bit more. So, yeah, so here this is a little bit older specimen. So this is the DOI with remote VSD. Yes, so of course, this is absolutely remote from aortic valve and pulmonary valve behind, very, very remote. And this is also remote, but however, a little bit closer to the semilunar valve. This is one. And in the short axis view, you can see this VSD channel is remote from both arterial valves. Here in this case, how do you define? This is the so-called aorto left ventricular communicating channel. Well, very difficult. It's not possible. I think that is not the intention of your introduction of aorto right ventricular, pulmonary right ventricular tunnel or communication. But anyway, this is a VSD.
June, let me just stop you for a moment. Did I say it was possible to define that when the channel was non-committed?
You did not, but there is not this. No, I'm not arguing about that one. But I am just telling the people that concept.
Just let me speak from why are you introducing this confusing issue when I did not bring it up at all?
No, I did not. So I emphasize that aorto left ventricular, aorto right ventricular communication concept applies only when semilunar valve overrides. That's what I'm emphasizing. I'm not criticizing. Okay?
But I say
so I'm making your concept more applicable. Yes. Okay. Here, so what it is that this remote VSD is close to subaortic outflow tract. This VSD is close to subpulmonary outflow tract. So what I'm advocating to people is that when you define the remote VSD, always is better to define whether, defect is not baffleable to either baffleable to subaortic outflow tract and baffleable to pulmonary outflow tract. That is what I really want to emphasize. Yes.
But did I not say the same thing?
Oh, yeah, you did. Yes. But I was emphasizing that applies only for in the condition where semilunar valve overrides. But that would not apply if both valves override the septum.
Absolutely. But the other point is, as you say, if you missed, why go back, don't share, stop sharing your screen.
Yeah, so let me, okay, how can I do that? So where is it? I want to do, anybody can unshare it? Okay, yeah, here you go. I got it. Yeah. Oh, sorry.
So I don't think you caught up with us, because last week, last session, when we were discussing tetralogy of Fallot, we made the point that when we define a triangle of space, and now we accept it's a triangle rather than a cone, anywhere within that triangle of space, it's justifiable to say you have a ventricular septal defect. And in fact, it's the entirety of that space that is the channel between the ventricles. So I accept that some might like to call the left ventricular entrance the ventricular septal defect, which you do. I still think that the emphasis needs to be on the right ventricular entrance, because that, irrespective of what you're going to call the other part, is where the surgeon is going to place his patch. Do we not need to tell the surgeon where he is going to place his sutures so as to secure the patch?
100% agree, but you don't call that as a VSD, as you did not today.
Case, what will you call it?
No, that's fine. Surgeon review where to patch. You don't have to teach.
If you're not going to call it the VSD, what are you going to call it?
Why do you need to call it?
Well, why do you want to call the ventricular
I do not know why you,
you
have a separate name for that. Everybody understands that.
Right, okay. Why do we need to call, why then do you need to call the left ventricular entrance the VSD?
No, I didn't.
Oh,
And
okay.
people usually don't.
Right, okay. Oh, so we are reaching agreement. Let's just call it the defect.
Yeah.
Diane, you've been out of all this. We enjoyed again your lovely presentations. Do you have anything to add?
No, not really. I see what everybody's talking about. I agree with what you're discussing. I really don't have any other comments.
Adrian, do you have any more thoughts?
Just to go back to one important point that was made here about the bilateral infundibulums. And I will share with you some unpublished data yet regarding more than 300 tetralogies of fallow that we looked at. And look what we found. Regarding the ventricular arterial connections, that tetralogies that had double outlet right ventricle, look at the aorto-mitral continuity. It's almost in 50% of the cases present, in 50% of the cases not present. So it doesn't have to define a double outlet right ventricle, the presence of an infundibulum. Even more interesting, look in the concordant atrioventricular arterial connections in the tetralogy of fallow. We had, of course, we had a bit more cases with aorto-mitral continuity, so no infundibulum on the left side. But we had other cases, quite a few of them, with discontinuity. So we have to be clear, as you said, that there can be tetralogy of fallow with double outlet, without double outlet, without even implying that there are bilateral infundibulums or not. So that was an important point I wanted to make.
Go back, show us those pictures, those numbers again, because the percentages somehow don't add up.
No, it's not percentage, it's absolute numbers. It's a mistake there. It's absolute numbers, not percentages.
Right.
Yeah, but the one thing that here you might be careful about regarding that continuity, discontinuity thing is that actually you do have some distance in mitral and aortic valve and significant the number of normal individuals as shown in a number of years ago. And that is what you see even in normal. Yes.
Absolutely.
And the question is, that distance is actually having muscle or not? I do not know.
Indeed. Yeah. And Diane showed that beautiful specimen of an apical VSD with a subaortic infundibulum. And the point you make is a very good one. You cannot be sure whether it is fibrous or whether it is myocardial.
Yeah, I have some hearts where the subaortic infundibulum is only a 2 or 3 millimeter bar of muscle. So that infundibulum can vary significantly.
Yeah.
We did have one question that we have to answer from Jason Tan. How should we describe hearts with aorta from RV but pulmonary atresia? And indeed, I mean, if the aorta is exclusively from the right ventricle and there is pulmonary atresia, then that is double outlet with pulmonary atresia. And as he says also, we can't have double outlet and transposition, of course. We can have double outlet with pulmonary atresia and the aorta from the right ventricle, but we should not call it transposition because it would be double outlet. If it was, you can have transposition with pulmonary atresia when the pulmonary route can be traced back to the left ventricle. And that, of course, is the difference. So, do we have I don't think we have any other comments from anybody. So, June, thank you very much. I think we are moving eventually into agreement.
I mean, honestly, that I agree with you for 99% of the cases, but the disagreement arose when you said that surgeon closes the interventricular communication. That should be called as a VSD. That was the beginning of the right, and then I'm glad that you stopped doing that.
I'm just saying the surgeon places his patch so as to put the root back into the left ventricle.
100%, yes.
Right.
Yeah.
We
I
can,
think we'll be arguing about this in 10 years from now too, Bob.
we shall continue, but the focus needs to be, Norman, on the right ventricular entrance. We have to tell the surgeons where they're putting their sutures. And that's the bottom line. And I hope we have explained that. Have we got a new chat? There's something has just, thanks. Okay, from Lutz de Maria, so Sandoval Franco. Well, thank you for that, Lutz. We appreciate your comment. And we realize we don't have many people watching us live, but we do hope that many more will catch up on the YouTube. And June, thank you so much for being with us. Thanks, everybody. Norman, enjoy your trip to Portland.
Thank you, Bob. Thank you. Great session.
And Diane, thank you again for your splendid presentations.
Absolutely wonderful. And
Thank you for
Nice.
providing me
Adrian
opportunity.
too. Goodbye,
Good to see you.
everybody.